So my project is the characterization of parathyroid adenomas. And before I get into the project itself, I thought it would be important to give you guys some background. So your parathyroid glands are located in your neck. And you can see here that they're attached to this butterfly-shaped structure, which are your thyroid glands, and they're responsible for calcium metabolism in the body. So when your parathyroid releases parathyroid hormone, it causes uptake of calcium into the bloodstream from your bones. And an adenoma is basically just an abnormal growth of your parathyroid gland that can cause many complications. So to go into the significance of this project, an emphasis on developing medical technologies has contributed to this ongoing trend of excessive spending in medicine, right? So you look at Da Vinci robots, which are used to help in surgical procedures, this dependency on imaging exams, and even simple surgeries, right? They could cost thousands of dollars. And parathyroid adenomas specifically affect 80,000 to 85,000 new people each year in the US. And imaging exams for parathyroid localization can cost upwards of $200 per patient. So when you take into account all these new cases, that's more than $50 million a year. And as you can see in this graphic over here, the US spends almost twice as much as the next highest country in per capita health expenditure. So that just highlights this issue. So to go into background information, preoperative localization of parathyroid lesions, lesion being another word for adenoma, with either ultrasound, nuclear scintigraphy, or computerized tomography, or like a CT scan, allows for minimally invasive parathyroid surgery. More recently at Boston Medical Center, which is where I actually did this study since the summer of 2019, ultrasound has been the primary modality of imaging for preoperative localization. So the purpose of this study was to determine the efficiency of ultrasound for preoperative imaging and to outline practice patterns specifically at Boston Medical Center. So here's an example of a parathyroid ultrasound. The one on the left is a normal ultrasound, and as you can see, there's no protrusion coming out of the thyroid gland, which is labeled as right lobe and left lobe. But if you look on the right-hand side, you can sort of see this like darkish structure, and that represents an abnormal parathyroid growth or an adenoma. So for this study, there were a total of 295 patients included over a 5-year period from 2014 to 2018. And preoperative imaging reports, right, regarding ultrasound, nuclear scintigraphy, and 4D CAT scan, along with baseline laboratory results, right, like chemical testing, operative reports, and pathology results were also reviewed. For those of you who may not be clear, a pathology is just a description of the lesion that was removed, basically the location and the size of the lesion, along with certain defining characteristics such as shape and texture. So to go into the demographics of the study, there were a total of 295 patients, the majority of which were female. The average age was about 58 years old. When we looked at all the providers, since all these surgeries were carried out at BMC, the majority of providers were BMC endocrinologists, but there were also providers from outside hospitals that referred these patients to BMC surgeons. Chemical testing basically just confirmed that all the patients included in the study had parathyroid adenomas. Then when we looked at surgical categorization, we found that the majority of studies were focused, meaning that the surgeon had a clear idea of exactly where the lesion was based on preoperative imaging and could make the incision based on that imaging. For bilateral exploration, that basically indicated that the surgeon explored both sides of the neck. So I don't know if you recall the image on the first slide, but you have 2 parathyroid glands on each side of the neck, on the left and the right. So bilateral exploration would be making an incision on both the right and left side of the neck in order to search for the adenoma, since it wasn't super clear based on the imaging exactly where that adenoma was located. A unilateral exploration is just making an incision on one side of the neck without having an idea exactly where that adenoma is located. So when we looked at the number of lesions removed during the surgery per patient, we found that the majority of patients only had one lesion removed. And that kind of correlates with the fact that the majority of surgeries were focused surgeries, since it's easier to identify exactly where one lesion is going to be. When looking specifically at BMC providers, there were a total of 198 patients and a total of 315 studies. Studies just refers to all the imaging exams that were carried out, right? So that includes ultrasound, nuclear scintigraphy, and 4D CT scans. And the majority of the providers only had one study. When ultrasound was used as the first modality of imaging, it was found that only 44% of all cases had alternative imaging ordered, which is a positive sign, since that indicates that ultrasound is the most commonly used method of imaging. Clinical ultrasound findings, right? This includes all providers, not just BMC providers, found that there were a total of 264 clinical ultrasounds and 373 lesions. And the results basically reflected literature values, indicating that almost 70% of ultrasounds found at least one lesion correctly prior to surgery. And approximately 60% found almost all of the lesions. In addition to a clinical ultrasound review, there was also an investigator review of ultrasound, which was basically a review of all the lesions that were missed by providers. And this was reviewed by two renowned endocrinologists. And basically the results indicated that there were a total of 136 missed lesions that could be reviewed. So 96 were not identified by investigators, which indicates that either quality of imaging or just difficulty in locating that lesion made it impossible to rediscover where the adenoma was located after looking back at these missed ultrasound lesions. But 40 of them were subsequently identified by the investigators, which indicates that there is room for improvement in ultrasound techniques in locating parathyroid lesions. So the major takeaway from this is that ultrasound is an efficient form of imaging for preoperative localization. And given that out of all the missed lesions, an additional 40 were identified, this basically shows that there is room for improvement. The fact that only 43% of patients had some form of additional imaging studies ordered, including nuclear scintigraphy or 4D CT scan, is also a positive sign. And as a result, endocrine providers need to develop confidence in their ultrasound imaging techniques, right? And not rely on other imaging studies to reduce radiation exposure for the patients themselves and to decrease long-term healthcare costs. Right, if you guys have any questions.